Now, I would like to focus on two more drugs that also provide significant prognostic benefit. Sacral edema might be present in patients who are lying down position, and leg edema should be assessed as part of both left and right heart failure. And when both sides of the heart failure takes place, that is known as biventricular failure or congestive cardiac failure. Discussing about another important topic from cardiology section, that we have to practice not only the stable cases but also the cardiac emergency cases as well. So that's why we will focus on the heart failure now. So heart failure is basically loss of cardiac output again when the heart is not able to pump properly the blood and not able to maintain the oxygenation in the tissue level. So that is known as the heart failure. So heart failure is actually, broadly, it is divided into, depending on what time the patient has been presented with the features of heart failure. Depending on that, it's mainly divided into two categories, that is acute versus chronic heart failure, also known as acute versus stable heart failure. However, you can remember it, up to you. Most commonly known as acute versus chronic heart failure. And depending on the presentation, as the presentation is quite varied when the right or the left side of the heart is involved. Further classification is right heart failure versus left heart failure. And when both sides of the heart failure takes place, that is known as biventricular failure or congestive cardiac failure. Nowadays, according to the American Heart Association and the NYHA classification, so nowadays, based on the ejection fraction, there are further some categories. So only based on the ejection fraction, there are four categories. One is left ventricular with reduced ejection fraction, with mildly reduced ejection fraction, with preserved ejection fraction, and the other one is basically mild to moderate reduced ejection fraction. So, but that is again a very high level, like discussion. We will not focus on that here. In terms of acute left heart failure, so this is a medical emergency, which is why I will discuss it first and then the later part of the heart failure section. So in terms of acute heart failure, you have to consider taking history. This is very important. Of course, always any emergency situation start with ABCD resuscitation or assessment. Check the airway, oxygen saturation, vitals, breathing, circulation, disability status, and exposure. After that, establish an IV access, sit the patient in propped up position, and give patient high flow oxygen unless contraindicated. For example, if a patient is suffering from COPD or chronic obstructive pulmonary disease, in that case, you cannot give high flow oxygen for obvious reason. But most of the time, this type of patients, because there is lack of tissue oxygenation, so you have to give the patient high flow oxygen here. So important management is propped up position, high flow oxygen, open IV access, then send ECG, NT-proBNP, echocardiogram, chest X-ray PA view, full blood count, RBS. This important investigation simultaneously. Give diamorphine, IV. However, you have to be cautious if the patient is having COPD or liver failure, because in these particular conditions, like in COPD, it can cause cardiorespiratory depression and cause, in severe COPD in particularly, diamorphine is best avoided. This will help in reducing the chest pain. At the same time, will help if a patient is distressed or agitated, diamorphine will actually provide symptomatic relief here. So important treatment is basically GTN. So start with, like sublingual tablets, 2 tablets, 0.3 milligram, or you can give GTN spray underneath the tongue as well. And most important being the loop diuretics, that is furosemide. You can start with 40 to 80 milligram given via IV and increase the dose up to the patient's ongoing treatment. However, if the patient is having high blood pressure, so most of the time acute left ventricular failure common causes either malignant hypertension or because if there is a background of myocardial infarction. So if the patient is having very high blood pressure, in that case, like if the SBP is more than 100 millimeter mercury, In that case, you can give IV GTN as well, IV isosorbide infusion. But continuous systolic blood pressure monitoring is required here. So it should always be more than 90 millimeter mercury after starting with the IV GTN. Never less than that, because in that way, patient might be going into cardiogenic shock. Next up is you have to keep the patients under monitoring and check for the vitals at the same time. If the patient is still refractory, in that case, you can increase the dose of the loop diuretics. Okay. And you can also consider some additional measures such as continuous positive airway pressure or CPAP. So what it does in acute heart failure, we know that there is fluid accumulation within the lungs, like within the alveoli, in the interstitium, right? So in CPAP, it actually helps driving this fluid back into the capillary, okay? So thereby the alveoli that was collapsed due to this increased, like fluid collection within the interstitium, they will be able to, collapse or maybe, like inflate properly. So in order to drive the fluid out from the interstitium into the alveolar capillary, CPAP can be given, and it will provide quite a good benefit, like symptomatic relief to the patient. If the patient is still being refractory, in that case, treat it as a case of cardiogenic shock and refer the patient to ICU. And in the ICU, sometimes they usually start with intra-aortic balloon pump here. Intra-aortic balloon pump to increase the cardiac motility. So these are basically the steps of management. You just only have to focus till the point of CPAP or, like mainly IV diuretic, morphine, GTN, high flow oxygen, propped up position, increase the diuretic dose. You can give IV GTN as well, as long as the blood pressure is more than 100. And you can consider CPAP before sending the patient to, with a consultation of respiratory physician in the general ward even. And if the patient is still refractory, in that case, refer the patient to the ICU and treat it as a case of cardiogenic shock. This is the treatment algorithm for acute left ventricular failure management. Now, we will discuss on the chronic heart failure. All right. So chronic heart failure patients, there are particular medications which have significant prognostic value. So, for example, one of the most important being spironolactone or aldosterone receptor antagonist. Another one is eplerenone. Some centers give eplerenone as well. But do remember that thiazide and loop diuretics, they do not have any, they only provide symptomatic benefit. They're, used in the acute management, but they do, in the long run, furosemide or thiazide diuretics, they do not have any prognostic benefit or value. Number 2 is ACE inhibitors or ARB or angiotensin receptor blockers, because they help in reducing the afterload. Okay, and number 3 is this is a relatively new medication. So this is a combination of angiotensin receptor blocker plus neprilysin inhibitor. This is also known as ARNI. ARNI is a very similar group to this ACE inhibitor ARB because it has combination angiotensin receptor blocker and neprilysin inhibitor. So in order to understand how does a neprilysin inhibitor work, I just have to draw a diagram, I think. Okay. So BNP or brain-derived natriuretic peptide, ANP, atrial natriuretic peptide. So these are some peptides that are released from the myocardial stretching. If the myocardium is under, so these are naturally occurring peptides that are released when the myocardium is under some sort of stress, angina, or any type of, under any stress condition, these peptides are naturally synthesized. And what they do is they have a little bit of natriuretic property. So natriuretic property, by that I mean, they help in, salt and water excretion through the renal tubules. So pro-BNP, on the other hand, so this BNP is actually released as a pro-peptide. This is known as the pro-BNP. And pro-BNP is further divided into like BNP and N-terminal pro-BNP fragment. So this actually, that's why you will see like in heart failure patient, NT-proBNP is usually measured to see the heart failure, not only as a part of diagnosis, but at the same time to see the therapeutic monitoring as well as prognosis of the heart failure patients. So this cleavage is this cleavage of the pro-BNP is done in the presence of a particular enzyme known as nephrilysin. So the nephrilysin is actually good for the body because with the nephrilysin enzyme, when the pro-BNP is cleaved into BNP, and this BNP helps get rid of excessive salt and water retention in the body. So they cause natural diuresis in the body. They act as natural diuretics. So we do not want the nephrilysin to be working during a heart failure event. So that's why nephrilysin inhibitors are used in the management of heart failure. So this medication also has significant, prognostic benefit. One example of nephrilysin inhibitor is the sacubitril. Sacubitril plus valsartan combination. This is the common combination that is currently under the market.